Hello, and thank you all for joining today's webinar, Can Telehealth Support Integrated Mind-Body Care? I am Mary Giliberti. I'll be your moderator today. I am the Chief Public Policy Officer for Mental Health America. I'm also a proud member of the Primary Care Collaborative, PCC, which is our host for today's webinar. PCC is a multi-stakeholder organization that does public policy and shares best practices to promote high quality, high performing primary care and medical homes. Some housekeeping for today. All lines are automatically muted, so don't worry about that to hear the presenters. We will take questions from the audience in the last 10 minutes or so. So if you have any questions, just put them in the chat. And the webinar is being recorded and slides will be shared as well as the recording within 24 hours. So don't worry about taking notes, that'll all be provided to you. Today's topic really is incredibly timely. We know with COVID, we have seen unprecedented increases in the need for mental health and substance use care. COVID threw fuel on an existing fire, right? And if there's any silver lining to this very dark cloud, it's that the delivery system had to change to adapt to this. We knew we weren't going to have enough mental health providers, so we needed to start looking at integrated care. We know that we couldn't do as much in-person care, so the entire industry just kind of shifted. Healthcare moved to telehealth. And so today, we really get to talk about the best of those two shifts and how they interact together. I think about this as like the peanut butter and chocolate webinar, right? These things are good separately, but they're amazing together. And so we're going to have a conversation about how payment interacted with that, practice changes, the overall scope of what's happened. I'm really excited to have these amazing panelists join me today for this conversation. Our first panelist is Dr. Ben Miller. He is the president of Wellbeing Trust, where he oversees the implementation of the foundation's strategies, planning, partnerships, and investments to make an on-the-ground difference in the addiction and mental health crisis we are experiencing. Prior to that, he was the chief strategy officer. He also has a weekly newsletter, Mental, Fighting the Fragmentation of Mental Health One Policy at a Time. I love that title. He also worked at the Eugene and was a founder of the Eugene Farley Center for Health Policy, which will study many of the policies that we're going to be talking about today, and he's a psychologist by training. We're also joined by Dr. Bill Beecroft. He's the medical director of behavioral health for Blue Cross Blue Shield of Michigan, where he oversees the medical administration of the Blue Cross Blue Shield of Michigan's behavioral health, and he does the strategy and planning. He has been instrumental and a very strong supporter of collaborative care and that model, which we'll talk about today. He was trained in internal medicine and has 38 years of experience. He's a general practice, board certified in general psychiatry with additional qualifications in geriatrics and consultation liaison psychiatry. That's a mouthful, but very relevant to today. Kim Coleman is our last panelist. She is a primary care physician with more than 25 years experience in office-based pediatrics. She currently serves as the Chief Medical Officer for United Physicians, which is a large independent physician organization. In her role, she supports over 300 adult and pediatric physicians in Southeast Michigan, and she has overseen their recent collaborative care program in partnership with Array Telebehavioral Health, very relevant to what we'll be talking about today. So each of our panelists is going to give 5 minutes of opening remarks. Then I will come back and join you for some Q&A with the panelists, and then we will take some questions from the audience. Ben, take us away.
Thanks so much, Mary, and a major thanks to the PCC for the chance to talk about this critically important issue. As a friend and mentor of mine, Dr. Frank Degree wrote for the National Academies almost 30 years ago, mental health and primary care are inseparable, and any attempts to separate the two leads to inferior care. Dr. Sandy Blunt, a mentor of mine, shortly thereafter in 1998, wrote a seminal book, Integrated Primary Care, which he began to outline what mental health delivery looked like in primary care settings. Each of these approaches centered around bringing mental health to where the patient was, and recognized that while primary care was the largest platform of healthcare delivery, it wasn't excelling at addressing issues of mental health. In 2002, the first IMPACT trial occurred, which introduced the world to the collaborative care model. These trials, which were based on the initial name, Improving Mood, Promoting Access to Collaborative Treatment, we academics love our acronyms there. It primarily focused on depression, at least initially, and contained several unique elements, which at this time were almost non-existent in primary care. I mean, for example, it brought mental health clinicians and care managers into the care process to help manage and address the patient's mental health needs. It leveraged measurement as a way to best treat to target and focus on outcomes. It brought a team approach. For collaborative care, this team was mainly led by a psychiatrist, but for other models, it wasn't the case. And herein lies the beauty of integration. It's about creating the team that includes a mental health clinician working alongside primary care. It's an extension of the primary care function to be comprehensive, which obviously this day and age we know includes mental health. But let me take us back for just a second. As a mentor of mine said, you can't win health one problem at a time, but integration does begin to solve some of this. Any frontline clinician knows what a disaster it can be to try and manage the average 55-year-old primary care patient's 6 active chronic problems by implementing 6 different disease protocols. You get totally tangled up and you run out of time. It's frustrating for you, the patient, their family. Primary care takes care of patients, not problems. It's always patients in the context of family and family in the context of community. And this requires formulating this coherent and comprehensive personal care plan. One plan per patient, dividing into discrete problems is doomed to failure. And further, carving out problems is more of a disaster, which is why integration is so much of the solution. Many reviews of the evidence that say patient-centered don't even really get to the heart of what that means, which is why integration must be seen as a fundamental part of primary care. It's what people want. It's what people have begun to expect in some parts of the country. This team, though, needs to be flexible in what it does, who it sees, and not find itself limited by constraints of a disease-specific mindset, which is why when we get into the weeds on integration, we see the endless possibilities of what could be. So today, you're going to hear about a really important topic, and I'm looking forward to having that discussion, one that's needed now perhaps more than ever, as Mary mentioned. You'll hear words, integrated primary care, collaborative care, integrated behavioral health, telehealth. And these different phrasings, these different lexical offerings, they all point to the same thing, bringing care to where people are in primary care, bringing mental health there. It works for people as they have to rely less on this fragmented system that can rarely see them in a timely manner. The status quo in US healthcare delivery is such that mental health concerns are largely addressed by separate and distinct specialty mental health and private care settings. Integration works to fix that, but only when seamlessly done. We have to be careful not to replicate the problems on the outside in a primary care clinic. Even when you integrate mental health, sometimes we do fall victim to seeing it as a separate service line, and that's not a true part of the primary care team. We need to make this more seamless. Language matters here. So I want to address 2 things really quickly before I turn it over to my colleagues. But first is that in any and all discussions on integration, we need to talk about our workforce. Who is doing what? Our mental health workforce is often ill-prepared for integration, and we need to fix that. In integrated settings, mental health and addiction clinicians must be trained as generalists, not specialists, to see the myriad of issues that come at primary care. From social issues to mental illness, the team members together are doing primary care work. Simply taking a mental health clinician from their specialty setting and putting them into primary care brings out these inherent tendencies that we have to want to do specialty care, which leads to only a backlog of patients waiting to get in. Referrals are divisive and oftentimes don't work, even when they happen in the primary care setting to the mental health clinician down the hall. They perpetuate fragmentation and in some cases even further stigma. Trying to train a new generation of mental health clinicians to tackle this issue is a priority. Second, we need to allow for local adaptation and creativity in how practices integrate. Being overly prescriptive does not always work in primary care practices. Consistency is fine and important, but primary care needs the flexibility to be able to adapt their mental health work to their community and to their workflows. Communities have unique needs that require a primary care practice, the place that most of them established as their go-to touch point for healthcare anyway. They need to be responsive to those needs. Setting parameters around integration that align with a clear definition means that practices can pursue the model that works best for them. I've seen too many practices fail trying to integrate, to know the challenges of protocolizing one's way into a new care pathway. It just doesn't work that way for most folks. I've worked most of my career on this issue we're talking about today. I've been proud to lead practice level payer and policy efforts. I've seen the success and failure, but most importantly, I've seen what happens when we get this right. To the patient, to the family, when they get that seamless care that they need. That's why I keep showing up on webinars like this, because I think it should be the new standard of care. I think it's what we should be aiming for. Scientific evidence simply will not allow us to proceed anymore as if mental health can be separated from primary care. Now is the time for this integrated approach to be the standard. Let's take that opportunity that we have today and let's look forward to the discussion. So I will turn it over to Bill.
I think it might be good if Kim could go next, and we'll work on getting the sound for Bill connected.
Hear me now?
Oh, Bill, I can hear you now. Do you want to go ahead?
Okay. Sure, I can go ahead and start over. I'm sorry for the technical issues here, but something has happened.
Okay.
Stephen, can you move on to the next slide, please? And I'll make it quick. So thank you very much for the time today. I'll start from where I began when I was on mute. Thank you for the PCC to be able to give me an opportunity to talk about one of my most favorite things to talk about. With the collaborative care model, this is a integration model. I want to stop that. Okay. It is a integration model, but it does factor in the consulting psychiatrist, which is a consultant to the practice itself. It's not to the individual patients that are involved in the practice. It's through the behavioral health care manager and the primary care provider that information gets to the patient themselves. It's coordinated through a systemic case management tool and on a routine evaluation of each of the patients that are involved in the care in that practice each week, ideally to be able to status where they are. It's really focused on the issue of team medicine and being able to have a search of the entire practice population for people that have, in this case, depression and anxiety disorders, but it can be used for other areas too. Next slide, please. We found that there was a significant number of our first adopters that utilized this practice and really helped us to kind of move into this space much more aggressively. It was based a lot on the business case, was based a lot on a 2014 Milliman report that, as you see there, 14% of people with insurance had a behavioral health condition, and they amounted for approximately 30% of the total healthcare spend. Most of that was in the medical space. When they look at the cost of the treatment of the behavioral health conditions, it was relatively small compared to the medical surgical spend that those individuals needed. When you add in quality of life, decreased ability to be able to be in the work environment, and productivity, it's substantial. But ultimately, when the actuarials come out to looking at this, there's a 2 to 3 times return on investment that can be had by treating people with behavioral health conditions simultaneously to the treatment of their medical conditions. An example that I always use is a person with diabetes and depression. That person just doesn't really get very well. They tend not to be able to get their A1Cs to target. They also don't get their PHQ-9s to target. Whereas if they're treated together, both issues treated together, they can be able to reach those numbers very, very more frequently than what they would otherwise. Next slide, please. So we have had a program that has been looking at expanding this model. Our treatment and training partners have worked very well together. We've had a development of the curriculum with University of Michigan and the Michigan Center for Clinical Systems Improvement that has worked for the traditional collaborative care model. We've also expanded that into a pediatric module, and we're looking at other modules that may be beneficial for this model to use. We launched the collaborative care program in 2020, and in that period of time have trained up 180 practices, which amounts to about 590 individual providers, which is pretty substantial to be able to do in that period of time. We've also had the adolescent pilot going for a while, and we've had 18 practices that were trained in 2021, and we have more scheduled for 22. And when you look at it, we've been able to reimburse with incentivization about 800 primary care providers that have actually been trained and are practicing, submitting bills to us for the collaborative care practice team medicine project. If you look at the map, this really includes approximately 85% of our population that we have in Michigan. We are still looking at expanding to those other counties that aren't covered with a practice at this point. But next slide, please. It really does show that we're moving on to expanding this very, very rapidly. This is the number of claims that we've had, and you've seen the growth has been very substantial. But this also represents approximately 4,500 unique members, and this is growing on a continuing basis as we go along. Next slide, please. In this process of education, we have been able to find really significant barriers in the initial configuration of the codes and how they've been able to work out. We've had people bring this up as many of these barriers as reasons not to do this particular practice. But we've done ways of being able to mitigate these barriers with Blue Cross Blue Shield of Michigan and working with our partners to be able to really fine tune this. Code configuration was one of them, reimbursement, copays. All of these things have a solution, not only a local, but also could be a centrally modulated solution that could help this expand more broadly. So I will pass it off to Dr. Miller here. She's been one of our great advocates and partners in this process of being able to develop this and move it on. So Dr. Miller, it's up to you.
Thanks everybody, and thanks Bill. Well, it's a pleasure to be here and share the provider perspective on collaborative care. So I think, as Mary had mentioned, I'm a pediatrician by trade and very acutely aware of the challenges associated with appropriately managing patients with, depression, anxiety, or other behavioral health issues in the primary care setting. Access has been a challenge. So in my role at United Physicians, I support our participating practices in a variety of clinical initiatives, including the behavioral health co-care. And I have to say, Bill said it's his favorite topic. This is one of my favorite programs. And the reason is, when I go out and I talk to practices about participating in this program, they're so appreciative that we're presenting them with a solution to something that they've been struggling with. So our practices are all independent. They have no formal health system affiliation or support. As Mary mentioned, we have about 300 primary care providers. And this really is one of their biggest pain points. When I go out and talk to them, access to mental health, two big concerns are the delays in accessing treatment and the amount of staff time it takes to help patients navigate. So, some of our PCPs kind of jumped in and said, this is so difficult, I'm going to start managing meds for mild to moderate depression. And I think that's great. The thing that we found is oftentimes they didn't have the capacity to closely follow that group of patients. And likewise, kind of got stuck if the patients weren't responding in a real predictable and favorable way. So we've been working with Blue Cross on integrating behavioral health for, we had collaboratives going back about 5 years. And we just always were bumping up against challenges in terms of trying to bring this to market. And our first challenge was the reimbursement. I think Bill mentioned that, but Blue Cross was really instrumental in opening up those co-care codes. And I think equally importantly, waiving the member co-insurance for co-care. And it really was once that happened, we were able to see, okay, we might be able to operationalize this and put together a program that would support our practices. Our next challenge was the fact that our network is geographically distributed. We're not in one building or one medical center. So that was a challenge. And many of our practices are small. They're either solo or small group. And we have a couple really big ones, but we have a whole bunch of really little practices. So that, coupled with a shortage of local psychiatrists who had capacity, that was the next thing we had to kind of overcome. The other thing is we didn't have behavioral health care managers. We had a very robust team of chronic disease care managers, but to move forward with this, we had to either hire them and train them or find existing behavioral health care managers. So I did something kind of unusual for me. I get lots and lots of unsolicited emails because I touch so many different areas of healthcare. And for some reason, in 2019, I opened an email from a company called Insight. They went on to configure and become a company called Regroup, and they now are Array. And I was intrigued because they offered telebehavioral health services, and it got me thinking maybe they could help me with consulting psychiatrists. As we started working together and collaborating over many, many conversations spanning, I don't know, close to 2 years, I think, we were able to create a model, very, very purpose-built, that where we would partner to have them provide the professionals, the behavioral health care managers, if you think back to that diagram Bill showed, and the consulting psychiatrists, all virtually. So we went live in May of 2021 with 6 adult practices. We've now expanded the program to close to 20 practices, and we have over 100 adult, family, and pediatric PCPs who are currently offering integrated behavioral health to their patients through the co-care model. Bill mentioned there's a couple different ways to do this. I think this would be a really tough program for a small practice to do without an organization like ours. So we support the program centrally, both financially and administratively. It's 100% telemedicine based. There are no in-person visits. We use the AIMS systematic case review tool to support the BHCMs in managing their caseload and tracking their time for billing purposes. And really all we expect from our providers is that they get educated on the model, that they commit to participating with fidelity to the model, that they screen eligible patients with the GAD-7 and the PHQ-9, and we ask that they refer patients with scores of greater than or equal to 10 and meet with the behavioral health care manager on a regularly scheduled cadence to track patients' progress to goal. They also have access, and this is one of the things that's really appealing to them, is that they have access to the consulting psychiatrist on demand. We do sort of like office hours. So if they have a question about a patient, they're able to get some expert advice. At the end of 2021, our team, so when I look at the numbers in December, and we continue to grow, but we were doing about 800 visits per month and carrying a panel of about 250 patients. And although it's early, and if I could get the slide, I can show this, we are seeing consistent 3 to 4 point reductions in the average PHQ-9 and the GAD-7 scores. So if we can advance to that first slide. This shows our PHQ-9 scores at the beginning and at the end of the month. So it's the average of all entry scores during that month. And then at the end of the month, it's the average of all of the most recent PHQ scores. And you see a really nice drop. And what we're looking to see is that difference being sustained over time. And if I could just have the next one real quickly. So this is PHQ-9, and I think, and this is the GAD-7. So it's similar kind of shape. So we're really, really pleased with the early outcomes. And I have to say, this has just been a wildly successful program for us. So I'm going to turn this back over to Mary for questions.
Great. Thank you so much to each of our panelists. You can see why this is a very interesting and exciting panel that's been doing incredible things with respect to collaborative care. Kim, since you've joined me and we're waiting on some of the others, I'll start with you. You know, there's always people who have concerns when a new program is rolled out, right? There are always those that say, but what about this? But what about that? Can you talk a little bit about some of the concerns that you heard, especially from small practices? A lot of people worry about them in particular, and how you kind of overcame that initial, you know, concern and about anything new. Because sometimes people just, it's new, they're not sure they have the time, they're feeling overburdened to begin with.
You know, this is one of the reasons I love this program, is it really sells itself because it's a solution to something that they've really been struggling with. So, you know, you're right. When you go out to a practice, especially I've seen after COVID, a lot of these practices are, you know, very stressed in terms of staffing and, you know, the workload, the demands of the patients. I think this is just a really easy you can articulate the benefits of participating in this very, very simply. And I don't think it's hard for the provider to see that. Plus, we're kind of showing up and saying, hey, you're going to have this whole team that's going to help you out. So whereas treating these patients maybe was kind of an extra burden for the primary care physician, it's actually easier in this model.
And I guess you mentioned a couple times the workforce, that you provide the workforce and that it's a big issue to have these case managers, to have the workforce. Ben, do you want to address the importance of sort of the practice changes that have to take place and the workforce changes to really make these models overall successful, not just this particular model, but in general, the integrated care models?
Yeah, absolutely. One of the most unique experiences I got to have as a professional was when Colorado decided to integrate into over 300 primary care practices using its state innovation model dollars. And I got to tell you, Mary, it's very apparent how excited people are about the possibilities of what integrated could be and how ill prepared we are as a workforce to actually implement. And I said a couple of examples of this in my opening remarks, but I'll go a little bit deeper here. One of the first things that we did as a state was we established, based on the literature, what the competencies were that should go into a mental health clinician working in primary care. And there's actually a tremendous amount of literature on this topic, but we knew that we couldn't just say, hey, here's the literature, go and read it. We knew we had to put it into some type of format that people would use. So we synthesized it, put it into these very short video vignettes, placed it on YouTube, so that providers, both primary care and mental health, knew what they should be expecting from one another. And actually, the website's still out there. It's called makehealthwhole.org. And it was our entree into discussing these larger issues of workforce because we wanted people to be more prepared. So that's issue number one. You got to have the competencies. Issue number two, which my colleagues already addressed briefly, is that you have to have clear pathways within the care environment. Having a clinician that shows up a half a day a week doesn't allow for consistency in how you create those pathways. And actually, what we used to call this happy accidents, when there would be a positive outcome, because you really didn't know how that person was consistently getting engaged with the mental health care. And so having a person that's routinely there, having it fully baked into all your pathways, makes this much more of a comprehensive part of care. That's a workforce issue. And it begins just as much at the front desk with the person checking in the patients as it does the physician that's signing off on the paperwork at the end of the day.
And Bill, do you want to get in on this as the payer? How did you think about these workforce issues and how did you kind of support changes to the workforce overall?
Sure, access has been a significant issue, and we know that the primary care setting, about 35% of the patients that come into a primary care office have a primary psychiatric or behavioral health issue. Many times it doesn't go diagnosed. So really being able to help the primary care practices to be able to identify those people, to treat them, that's going to be able to improve access. It also, one thing that Dr. Coleman had brought up is the issue of the satisfaction for the practitioners. When I go to medical directors conferences and our regional medical directors meetings, I keep on hearing 75, 85, 90% of us are burned out. I don't want to be a doctor anymore. I want to do something else. And after the collaborative care program has really gotten hold in that practice, that they've been doing it for a year or so or more, I hear, I really like medicine again. I like doing what I'm doing. I feel supported. And that is an extreme value for us as practitioners and to taking care of our other colleagues in this area. The psychiatrists doing this also really like it. So it's something that gives that team that energy again to be able to work and do better work than what they were really slogging through and doing on a day-to-day basis. So it's a huge improvement that way. And we saw this as a way of supporting our primary care network, our psychiatry network, getting more access for our membership, and being able to really make the system work better and work smarter, not harder, to be able to get this task done.
Yeah, what a win-win-win, right? I mean, I haven't really thought of before of integrated care as a solution to burnout. So that's like a really interesting concept for us to hold on to. And it is a win-win for the patient experience too. And I thought, Dr. Coleman, can you just talk a little bit about, what you're hearing from the practices with respect to how patients are responding to this?
Yeah, so the patients really enjoy the program. I mean, basically there are some patients who opt out. So they're offered the opportunity to participate. We explain a little bit about you're going to have a behavioral health care manager. They're going to be checking in. What we've found is they're improving much quicker. They're reporting better overall kind of quality of life scores at an earlier point in time. And I think really having that behavioral health care manager in addition to their primary care provider, and knowing that this is taking place in the primary care setting. It's extremely frustrating from a patient standpoint trying to navigate access. We talk about the frustrations from the practice side, but it's probably, it's at least that bad for patients. Extremely expensive. So having this be offered through their practice, they've been really thrilled.
Well, that's interesting that you mentioned that you measure not only the GAD-7 and the PHQ-9, which we saw, but also a quality of life measure, a more general sort of how's your life going. And I know that many times people with these conditions talk about how they like measures that look at that broader kind of how are they doing in general. So that's very interesting. Are there any other measures, or are those the primary ones that you use to gauge success?
I think those, and then also just some of the just basic process metrics in terms of, keep in mind, this is new for us. So like we saw our first patient May 24th, and we've been adding practices left and right. Blue Cross opened up the ability for pediatric practices to participate in September. And we have several that have done that. So we've really been kind of trying to run to get practices in this model as quickly as possible.
And what are those process measures you mentioned?
So looking at, what's the optimal, we don't know really. There's literature that indicates what the optimal caseload is, what the duration of time that patients remain in the program. So we're collecting all that data, and that is one of the things with Blue Cross. Sharing that with them, you're getting data from the entire state on these patients and how they're doing. I think some of the other things that we learned very, very quickly is before we'll go live with the practice, they have to have a pretty rigorous review for change readiness, as well as dedicated individuals. The training program that Blue Cross supports is pretty, it's very robust. That's not just pretty robust, it's very, very robust. And, there has to be that level of commitment. We've also found that we do encounter patients who have much more acute needs, who are presenting in primary care and having a very specific to the practice, but well thought out process for escalation for acute mental health care is extraordinarily important.
Really important. One of the issues that is a major concern, I think, in healthcare today is equity in healthcare in general, but certainly in mental health and addiction care. So I'll start with you, Ben, if you could comment a little bit on this model, how it generally affects equity, how telehealth affects equity, and then I'll ask the other panelists if they want to weigh in on any of the equitable, both racial, other demographics, and how people are able to get access to care through this kind of a model.
Thanks for asking that question, Mary. I think that weighs very heavy on those of us that have been in this field for some time, because we've seen the increased disparities that are just so obvious right in front of us every day. I think this does a couple of things that really helps address that. And number one, as I mentioned earlier, it begins to bring care to where people are. We know that there's a profound stigma and in some communities a shame associated with seeking out mental health care. By making it much more easy for you to talk about these issues in a place that you have a relationship, you're more likely to talk about it. And most folks that when you say, hey, who do I go to talk about what's going on with my health, they always usually will say their primary care doc. And so if the primary care doc has a trusted agent in-house that they can also speak to, that does help provide a much more easy pathway for folks to have their needs addressed. But secondly, and this is a concern I have very much so around disparities, is with technology. We know that not all communities have access to technology the same way. And we've seen that through the pandemic just based on the data. But we also know that technology sometimes reinforces that false sense of siloing that is also very apparent in healthcare. Excuse me, I said that backwards, but sometimes it reinforces a siloed mentality where if I'm using a telehealth for my mental health and I'm not having a mental health clinician talk to my primary care doc, then am I furthering the fragmentation? And that will only exacerbate some of those disparities that we know. So I think it is an opportunity, but like many things using an equity lens, if we assume that one size will fit all, then we'll fail.
Kim, Bill, anybody else want to weigh in on equity and how this has affected that?
I think it really does accentuate that in having a local shoes on the street case manager that's working with you to be able to look at your community, being able to look at your family situation, to coordinate all of those things. If you have difficulty being able to get a copay for, say, an antidepressant medication, then being able to look at, well, can we find samples? Can we look at some way of getting into one of the drug companies' reimbursement programs? Being able to look at food resources because of a person with diabetes maybe living in a food desert, and being able to get adequate high proteinaceous food for that individual rather than high carbohydrate foods is going to be in everybody's best interest here. To be able to look at all of those kinds of things in that community, in that environment, those are things that really help to improve that equity and be a balancer of that equity issue, that they get good care, not just care that's available for them in their community.
I would just add, I think one of the things that drew us to the telehealth model was the fact that it was more accessible for a larger number of people. So, the challenges associated with getting the patient in when the behavioral health care manager is physically in the office, those sorts of barriers we don't have. The patient can be at home and interact with the behavioral health care manager in a very, very comfortable and convenient way. Now, we prefer face-to-face video, and we know that that's not an option for everyone, but a lot of the work that the care managers do is telephonic as well. So that, and that really is very, very accessible. So we think it's actually probably helped us in terms of some disparity and equity issues.
So in addition to talking about equity, I also wanted to raise the issue of children. So the Surgeon General issued a national advisory on children's mental health, protecting children's mental health. We've seen the American Academy of Pediatrics, along with psychiatry groups and hospital association, children's hospitals, declare a national emergency. And we know that this also is an issue for children of color, right? It's even more of an issue in some ways. So I'm curious how the model works for children. What is different about it, if there's anything different, and why is this a good option if it is for children? Kim, do you want to start us with that?
Yeah, I can start. So I agree 100% in terms of the acuity of the situation. One thing we've observed is we are getting referrals, and we're finding patients that are much more severe than what we were expecting. And part of what we're finding we're having to do is kind of help them navigate to a more appropriate. But this model really is for moderate depression and anxiety. So we've been kind of surprised by how many kids are actually too sick for this. Mm-hmm. In terms of how it works differently, it's kind of like the pediatric office visits. You've got more parties to bring into the discussion. You've got parents that might want to talk to you independent of the child. You've got the child, and then you've got both. So we do adjust in terms of the time we allow and the caseloads for the behavioral health care managers and the psychiatrists, because it's a little bit more involved.
Interesting. So more time to address both parents' issues, family issues, and the child's issues as well, and be able to talk to both. It's interesting. Anybody else want to speak to the issues of children? Ben, I see you want to jump in.
I got to jump in there because I think, well, first of all, I agree with what Kim was saying. I mean, those that have been on the front lines and have seen this work well know that there's probably no more powerful way to intervene with the child than with the family. And having that family connection, especially when it comes to addressing issues that are probably starting with the parents and are going down to the child, is so important. And sometimes that's hard to do. It's hard to convince a family to show up to a mental health office visit, but if you've got them in there for a well child check or whatever it might be, you have an opportunity to engage at a different level. And that's why going back to something I said at the very beginning is so important to me, is that we just make this the standard of care. Because when people begin to expect that taking care of their mind is just as important as taking care of their body, and it's really about that family context, then things do change in how we develop our measures, they change in how we develop our payment models, they change in how we basically think about public policy, which I feel like is a really positive direction for our country, because it will help those kids the more that we can get into the families.
You know, Kim, you were talking about how symptomatic some of the children are, how strong their symptoms were. Bill, you've talked before and mentioned how this could possibly be used for prevention over time. You know, how can we get more upstream a bit using this model so that over time we're not seeing children at the point at which they're so acute? I mean, you only started this last May, right? So these are children who lived through COVID and really haven't gotten any care through COVID. Bill, can you talk a little bit about how we could think about this more long-term as a prevention mode that, if implemented over time, could bring us to a different place if it became the standard of care, as Ben was saying?
Yeah, that's the effective part of screening. You're screening the entire population, so you catch these things earlier before they become issues. Kids don't come into the primary care office that frequently, maybe once a year for a physical exam for sports, or whatever it is that they're doing, or they may have a cold or flu or something. So you have to be able to grab that opportunity when it exists. The other thing that it really does is it gives you more access to child psychiatry services. As you see, this is a consultative model. We're not seeing people in front of us. In my practice, I could manage maybe 600, maybe 800 patients at any one point in time. But the idea here is that in the consulting model, you can, I think, a psychiatrist, and I've confirmed this with some of the folks at Mayo Clinic that have been doing this a lot longer than we have even, a good team can be able to manage probably 2,500, maybe even 3,000 patients to have psychiatric influence on their care. Not direct treatment, but influence on that care. And what I found as a consultant is that primary care doctors are awfully smart. They be able to figure out these things. And once they go through 3 or 4 cases that look similar, they know on the 5th or 6th case what to do. So they're asking you more difficult questions, not the simple ones anymore. So it really does help improve the skill sets of everybody on that team to be able to recognize these kids earlier, quicker, intercede quicker, and be able to prevent a lot of problems that are going on. And I think that's the issue of prevention here that is just huge in this model that can make a big difference.
Yeah, and we are getting to the point where I want to be able to have some audience questions. So this will be the last question for the panel. There were some policy changes, Bill, you gave a list of those, but not a lot of detail, that really need to change in order for us to make this model more of the standard of care. There are some barriers that we're seeing for payment, for other things. Can you each speak briefly as our last question to some of the policy issues that you think we really need to address in order to move forward with this model? I'll start with you, Ben, and just then Bill and Kim.
Thanks, Marion. I love the question. So while we've made great progress on the financial front on how we pay for this, I can remember years ago, everybody would always say the number one reason why we don't do this model is because we don't have the funds to do it. And now we actually have some codes that have emerged that CMS has approved, the collaborative care codes. Those have been positive. We had health behavior codes years ago that allowed for mental health clinicians to begin to bill out for things that were not just mental health related, that were actually more on the health side. But we're still not there yet. And this, to me, gives us the biggest opportunity. That practices are so varied in what they need. And because of the challenges of interconnecting systems and the challenges of each community being so uniquely different, it does feel like we need to have flexible funding that really goes into these practices to allow them to integrate in the way that's best for them. Now, I want to put a caveat on this. I do think there needs to be parameters around what integration is and is not. Okay, and a lot of literature has been published on this. We've talked about one model today, but I do think that there's an opportunity to set those parameters while still allowing the practices to be given things like a budget based on the population that they're serving, and have that budget really allow them to manage who they hire and what targets they try and achieve for outcomes. This has worked in parts of this country. We've seen this at a micro level. We have not seen this at a macro level, and I think that's an opportunity for policymakers.
Bill, what do you think? Policy
Well,
changes
there's a
that.
couple of different policy changes. I think the biggest one is going to be copays and being able to alleviate the coinsurance piece. We had a 55% rate of people stopping the collaborative care process after they got the first copay. This is a program that you have people that are really ill, and as a plan, you want to get them in treatment. You want to get them better. So why are you putting a barrier in place that doesn't allow them to be able to be a part of that, to be able to avail themselves of these services? You take a person that has, and another one that is one of my favorite combinations because it shows it so well. You take a person that's depressed, has hypertension, heart disease, and COPD. That person is probably not going to be very functional at work. They may not even be working. They may be on disability. And you're going to charge them an extra $20. You say, okay, $20, not a big deal. It is a big deal when you're on a fixed income, not making very much, and on disability. That's going to take you out of that system. If you treat that individual's depression, what we know is, and this comes from Milliman, is that person costs you substantially less to be able to, at the end of the third year of this program, they're down to almost the approximation of a normal person without those diseases, without depression.
Right.
In
so
the same age mass
group.
group.
Foolish.
So huge difference. Huge difference.
Dr. Coleman.
Bill stole my thunder. That's what I was going to recommend as well. I think the coinsurance is just extremely important. So kudos to you guys for working it out, and I hope more follow in your footsteps.
So I'm going to turn now to some of the audience questions. This is, I think, interesting for all of you. Can including this model in physician preparation? So, this is another one of those. We always work downstream. Once people are already trained, we're trying to show them a new model. Can that be an effective strategy to expand the value and impact of this? So who wants to tackle training? Oh, yeah. Go ahead, Bill.
Yeah, absolutely. This is extremely important for residents and medical students to be getting this training, for nursing staff to be able to understand team work, for our, I can't just say therapist colleagues because it goes over a whole bunch, but the people that we're going to be doing the case management section, which is going to be usually master's trained or possibly doctorate trained, but not so much likely on that. Providers, I think this is going to help the teams work much better, but they need that in their primary education, in their master's and doctorate level training. That's going to be really very helpful for them. And I'll leave time for my colleagues.
Well, I have to say, Mary, that one of the great things about this field is that a lot of medical schools have been training physicians to address some of the issues around mental health and expect integrated care for a long time now. And I can think of examples, Rochester, Colorado, there's a lot out there that we can point to. But I think the key here is that you have to acculturate the clinicians to know what it's like to be in teams early on in their training, which is what your point is. So why don't we have psychologists training side by side with future physicians? Why don't we have social workers working side by side with psychologists and pediatricians? I mean, that type of norming actually will lead to a place that we're much more comfortable when we get out and we're doing this on our own. I remember very vividly, I was doing a talk in Ohio at a medical school, and the chief resident was talking about his job propositions and where he wanted to go next. And he said, I chose the job based on the setting that was going to allow me to have on-site mental health clinicians, because that's how I was trained. That's what I expect for care. So I think that the training pieces, we've got a lot of literature on this that we can point to, but I actually think that we have made quite a bit of progress there.
And Kim, I just wanted to get another question in that someone asked. They asked, now this is like turning to something very different, which is like what's going on at the level of the practice. They wanted to understand more about the workflow. So how do you have an in-person primary care visit and then you've got the telehealth, and how does it all like fit together was the question.
Yeah, so one, it's really important that the whole practice understands the program and how it works. So, you know, it just can't be something that the primary care doctor mentions in passing and, you know, gives a phone number to call. So we have the patients are screened when the physician finds a candidate that he thinks or she thinks would be
now, they even asked who does the screening and how's the handoff go.
Some granularity. Okay. It varies practice by practice. Sometimes it's in the questionnaire. So most of the practices that are doing this have it hardwired in somewhere. And then that's reviewed and discussed at the time of the visit. We have a standard referral process. And then really, really important that from the time it's talked about in the practice, because we can't do a warm handoff, it needs to be about 24 hours that they get that initial call from a behavioral health care manager, kind of explaining a little bit more about how they would be working together, and then mapping out the rest of the steps. So I'm happy to take questions after too. And the logistics if anybody wants.
People can contact you about, because folks were wondering, you know, does the assessment go back to the PCP? So how does the PCP also get information back?
Two ways, in-person meeting video in-person meetings with the behavioral health care managers, regularly scheduled to talk about the patients, and then documentation. So they document in our EMR, which then the notes automatically flow back to the PCP.
All right, great. Well, I see that we are getting very close to the end, so I'm just going to ask for some closing thoughts from each of our panelists, and then we will wrap up. Ben, do you have any closing thoughts for?
Sure, I always have closing thoughts. Thank you, Mary, and thanks for my fellow panelists in the PCC for putting this on. It's great to have this conversation again. Just for those of you that might be new to this world, which I can't imagine in this day and age that this is a new concept for a lot of you, but hopefully if it is new to you, that you've heard something today you can take away. If we're going to solve the problem of fragmentation at a delivery level, then the most extreme example of good is by integrating mental health into primary care. There's multiple levels of what we got to get right, as we've discussed today. Telehealth is a major function that should complement and augment, in some cases, the direct provision of care that happens on site. This is a moment to really have these tough conversations. And I feel like in public policy at a federal and a state level, it's time for them to hear from us how much we want this to become that standard.
Bill, your thoughts?
I would agree that the telemedicine is here to stay. Sometimes in medicine, we've seen crises happen and really change technology and the way we practice. This is something that I think there's going to see going forward. A significant number, 60% or more of the behavioral health professionals will be using telemedicine as their primary means. That doesn't mean that all patients will be able to tolerate that or all members can use that service, but it's still something that is going to be a different way of practice going forward. And people tend to like it, which is the surprising piece from where we were two and a half years ago. There was concerns that would people like it? They do. So that's really important. If they like something, they'll do it.
And Kim, bring us home.
I guess I would say if you're a practice, don't be afraid to jump in. Keep an open mind and be willing to, you know, think creatively and a little out of the box to make this work. I led with, this is one of my favorite programs, and I'm going to close with it. It is a win-win-win, and it has been a breath of fresh air for our providers, and I think just a source of great value to the patients. So,
well, thank you so much to our amazing panelists for this really thoughtful discussion. Thank you to PCC for sponsoring this webinar, and we hope you have a good rest of your day.
Thanks, Mary.
Thank you for the time.